Okay, 7:30, we'll get started. So today's didactic topic is on neuraxial analgesia. And what I want to do is cover a few things. First of all, the complications associated with neuraxial analgesia. And you can divide these complications into about 5 categories: pharmacologic, physiologic, equipment-related, procedural-related, programming-related, and psychological. The overall incidence for all of these complications altogether is said to be around 44%, which is not a small incidence for problems associated with a procedure. Some of them are more serious than others, but you have to keep in mind that these systems, at least in this review that was done back in '99 and 2001, that the overall incidence was pretty high. So, paying attention to technique, orders for the drugs, etc., helps to reduce it, but still it's a significantly high complication for all these things put together. Okay, so let's look at some problems with pharmacologic and physiologic complications. So with the opiates, you can have, in the neuraxial delivery of opiates, you can have problems similar to those from oral or systemic delivery. So you can have GI effects, genitourinary effects. Itching occurs more with neuraxial than with oral or systemic. The incidence here was reported from that previous article that I cited, 12%, but I've seen as high as 30 to 40% of patients who get morphine neuraxial have pruritus. We see this on the acute pain service, and the incidence of pruritus with neuraxial epidural morphine is like 30–40%. You can also get constipation and ileus with neuraxial analgesia. It's not a direct effect on the gut, it's indirect effect acting on the neuraxis and slowing the activity of the gut. Sedation, confusion, hyperalgesia is reported. CNS effects can occur with intrathecal delivery. Now, many of you may know, but in case you don't, that sexual and hormonal changes occur with opiates. Here they estimated with neuraxial about 22% of patients have sexual or hormonal changes with neuraxial analgesia. The incidence for oral opiates long-term is something like a third, like 30% or so of patients. We'll have decreased libido, erectile dysfunction. Women lose their menses. They also lose their libido. So in men, if a patient reports that they have erectile dysfunction and loss of libido, you do a testosterone level. And you'll find in most of these patients that the testosterone is low compared to normal. And then you can replace the testosterone, and that can lead to normalization of their sexual dysfunction and their libido. In women, if women report it to me, I send them to the gynecologist and ask them for help with evaluating their hormones and giving them hormonal replacement to see if that would help. Now, another problem that can occur with opiates, whether it's neuraxial or oral, is peripheral edema. Now, peripheral edema occurs in a few percent of patients receiving oral opiates. Here it says 5% in those receiving neuraxial analgesia. What you need to do, a patient comes in, and it can occur at any time. It can occur months later, a year or two later. So it doesn't happen necessarily right away. The etiology related to the opiates is not understood or clear. But if someone comes in with peripheral edema, you have to rule out everything else first, such as cardiac, pulmonary, renal, hypoalbuminemia, etc. So after everything, so they get a medical workup, and after they're ruled out for all known medical causes for peripheral edema and nothing can be found, then you can make a presumptive diagnosis that the peripheral edema is related to the opiate. Now, what you can do, some patients will respond to diuretics, but not all patients. Some patients will respond to rotating the opiates, but not all patients. And so you have to be aware that if somebody comes in with a neuraxial infusion and they a few months later and they say my legs are swelling, that you need to have them worked up medically, but it could be the opiate that you're giving to them. Now, death can occur with neuraxial systems. There was an article in New England Journal of Medicine just a couple years ago, within the last couple years, that showed that patients who had pump implants compared to spinal cord stimulators had a higher incidence of death following the implant of the pump compared to the stimulator. And they surmise that it's an overdose of the opiate that's delivered in the neuraxial system that leads to respiratory depression. So that's one of the reasons why if I trial a patient with neuraxial analgesia and then they go for a pump, I want them observed overnight to see and to have them monitored for any respiratory or mental depression, because you never know. And so at least if they're in the hospital, it can be picked up, the pump can be stopped, you know, and so you minimize the risk of having death. But it's a serious complication, obviously. You need to be aware of it as one of the risk factors. And again, it was reported in an article a couple years ago, higher death rate with pumps compared to stimulators. The adverse effects on, from opiates has to do, in terms of their sexual dysfunction, has to do with their hypothalamic pituitary axis. The opiates will increase prolactin, inhibit growth hormone, and it'll lead to low luteinizing hormone, FSH and ACTH. So in males you get low testosterone and decreased libido, and you can get gynecomastia in some patients, again because it inhibits the release of gonadotropins that produce testosterone. They get hypotestosteronism. And females, you get amenorrhea, anovulation, and reduced milk production. So fluid retention and edema, we mentioned, can occur from the opiates. Exactly, the mechanism is not exactly known. It occurs in a few % of patients. And in some patients with neuraxial or any opiate, they'll report that they're cold and that they feel chilled or cold, and lower body temperatures from what they were baseline prior to the implant have been reported. So these are some of the things that you need to be aware of if you put pumps in and manage pumps. Okay, now other drugs we put in, that's the opiates, the clonidine. Clonidine is used, now clonidine is approved for epidural use, but we use it intrathecal. So it's an off-label use, but you just need to be aware that morphine is the only opiate that is recognized for neuraxial use. Clonidine is approved for epidural use, but not intrathecal. And So clonidine can produce cardiovascular effects, as noted here, central nervous system effects, as noted, and GI effects. And it can also produce endocrine effects with affecting insulin, antidiuretic hormone, and so forth. Baclofen. Baclofen can produce side effects, CNS side effects, depending on the dose that's given. You can get seizures and coma. It can also produce GI, cardiovascular, genitourinary effects as well. It can produce respiratory depression, and if too much is given, motor weakness and spasticity can occur. Now, baclofen has an antidote, physostigmine. So if you get an overdose with baclofen, let's say during a trial, you can reverse it with physostigmine. The dose, as I recall, is, I believe, like 2.5 or 5 milligrams, and you wait a few minutes and you see the results, and you can repeat it a couple of times. Physostigmine, you have to remember, as an anticholinesterase, can have its own side effects with bradycardia, increased salivation, increased bowel activity, and so forth. Okay, now, baclofen withdrawal you need to know about. You put baclofen into a pump and deliver it in the neuraxis. It's approved for muscle spasticity, for intrathecal use. But there have been reports of patients who have developed seizures, fever, coma, cardiovascular instability, exaggerated muscle spasticity and rigidity with rhabdomyolysis. They end up with multi-organ system failure from baclofen withdrawal, and death occurs in this scenario in about 25% of patients having this withdrawal phenomenon. This was reported in the FDA, and it is something that you need to be aware of in terms of potential side effects. So if you have a patient with a baclofen pump, with baclofen infusion in the pump, you need to make certain that they get in on time to have it replaced. You don't stop it abruptly, you taper it down. This syndrome, usually it's said to occur in patients, for example, with muscular dystrophies, like Duchenne's muscular dystrophy, or muscle disorders like myotonia, things like that. When you use it for pain, I don't know what the incidence is of this syndrome, but with withdrawal syndrome, but it seems that it's related more to individuals who have intrinsic muscular problems. Now, ziconotide is used for neuropathic pain intrathecally. Its action is on what's called N-type voltage sensitive calcium channels. Okay, so it's been shown to reduce pain in AIDS and cancer patients. It can have significant potential neurologic side effects. Can affect the gait and balance, can cause dizziness, mental status changes, it can cause coma as also. So it's hard to titrate ziconotide. You have to administer it and allow some time to see the effects. If you titrate too rapidly, you may end up getting some of these unwanted side effects. So just be aware that if you use ziconotide, you may not see a response right away, and you may not see side effects right away until it's been delivered for a period of time. Compared to morphine, it's been compared to morphine. It's 1,000 times more potent than morphine. It has analgesia. It's a very potent analgesic when compared to morphine analgesia. Okay, so another potential problem is compounding pharmacy errors. This occurs quite often, not so bad with Master Pharm that we have now. They have a reliable system with checks, and they send samples out for verifying that their preparations are accurate. But this was, there was a case we had maybe about 10 years ago, before we were using Master Pharm, using another company. And this patient had general widespread pain, back, lower extremities, joints, and Ehlers-Danlos syndrome with multiple joint pains, and had a neuraxia, failed many oral and systemic analgesic agents, so had neuraxial analgesia, had reasonably good effect, and had a pump implanted, and the pump had been in for a year or two, and she had come for a refill, and these were the drugs that she eventually ended up with. Fentanyl, bupivacaine, clonidine, and baclofen in these concentrations. This is what was ordered for refill for her pump. So when the syringe came, we checked the label, and we saw that the label had what we ordered, and the pump was refilled, and then within 48 hours of the refill, the patient was found by the family seizing and comatose, was brought to Beth Israel, was admitted to the ICU, and we were called because of her pump and the relationship of these events to her refill. So we saw the patient, and what we did was to withdraw the fluid from the side port, withdraw the fluid from the pump, and what we probably should have done was lavaged her CSF. We probably should have removed all of the CSF, in retrospect, removed 100, 150 cc's of CSF through her side port and flushed it with saline, and did that a couple of times. But we didn't do that. This was in retrospect. It was, you know, we didn't think about it. It was an unusual situation for us, and we didn't know really what was going on at the time. But because of the concern about the refill of the pump and the onset of these events within 2 days, here is the order, the syringe label. We sent the drug from the reservoir for assay. Here are the assay results. Well, this was shown to be close, and there wasn't much difference. Bupivacaine was shown to be close, wasn't much difference. Clonidine was shown to be very close, you know, not too much difference. But look at baclofen. So we had ordered 0.012 milligrams per mil of baclofen, and the results came back 11.6 milligrams per mil. And it was nearly 96,000 times difference. And we couldn't believe it. We said, it must be a mistake. So, and with these numbers, we knew that there would be a lawsuit, and that the family would sue because of it. So we asked the lab who did the analysis, and they hold on to the sample for like a month or two in case there is any question about the analysis. So we asked the lab to send it to another lab. So we repeated the analysis and got the same results by a different lab. The point is, pharmacologic errors in compounding do occur, can occur. It's less often now because it's more regulated and there are better controls. I remember there was a patient who had clonidine, and she had her pump refilled, and then she called a day or two later saying, I'm not right, I don't feel well, I'm lightheaded, my pulse is low. And so we had her come in. We withdrew the medication from the side port and from the pump, and we sent it for analysis. And the clonidine in her pump, she had, what other opiate she had, I don't remember, but the clonidine was like 10 or 15 times higher than what we had ordered. So again, there was a lawsuit there, not against us, but against the compounding pharmacy for it. So errors in, so if someone gets a refill and you get a call a day or two later that they're having problems, or they end up in the ICU, you withdraw your sample and send it for quantitative analysis to see what the results are, and you don't continue to infuse your drug. You clear it out. And again, in retrospect, well, if I had known what this was, and we got these results like a couple weeks later, because the quantitative analysis are usually done by labs that do police work. And so it's a question of priority. So if there's a murder or a homicide or overdose, so they may do some cases first, and yours may not be done for several days to a couple of weeks later. So we got these results a couple of weeks later. But with these cases that I just mentioned, from experience in retrospect, what I might do is lavage the CNS, remove all the CNS to remove the drug, and lavage it with saline. It's just what I would do. There's no guidelines that are official, but for you to think about. Equipment failures. So you can have catheter-related equipment failures, as noted here, pump-related failures, as noted here. I won't read them all, but I'm sure as you do pumps and implants, you'll see some of these occur. I forget who it was. I don't remember if, was it you, Dr. Mayhew, who we had a patient who had a shearing, a breaking of the catheter right where it connected to the pump. And the medication was coming out around the pump and not going into the central nervous system. Okay, so what's wrong with this? This is an old pump, but even if it was, this is from a real situation. Patient came in for a refill, couldn't access the side port, the refill port. X-ray was done, and this is what was seen. What's wrong with this? What? Speak up.
What?
Yeah, exactly. How do you know?
Writing.
What writing?
I don't know. The peak or the,
How do you know if it's flipped or not if you have it?
the apex of the side ports to the other side.
Okay, the connector is going to the left. Even in the new pumps, the connector goes to the right. So this was flipped, and we checked, you can see it here. Here's a syringe, and here's a needle. So we put a syringe and a needle in to make sure we didn't have the image flipped on the X-ray. And so this was correct positioning, so this was flipped. And what happened was it probably flipped during patient activity, at some point after the prior refill, patient may have moved or strained or something like that, and it flipped. I don't remember if we were able to rotate it back. I don't think so. I think she went for revision of her pump. Okay. Now, this is just to show you the template. This is the template that's used for refill. And again, the side port, connection port comes out to your right when you look at it, not to your left. Okay. All right. Procedural problems, well, any operation you can have infections, pump refill complications, external placement of the drug. This still happens. One of the fellows last year. What? I'm sorry? Oh, yeah, it still happens. One of the fellows last year refilling a pump said, I'm in, thinking he was into the reservoir system. And he started to administer the medication into the pump. And the patients became unresponsive. Respirations went down to about 6 per minute, had to be stimulated. And it was because she got all this opiate externally, subcutaneously, and it happened within about 5 or 10 minutes that she became unresponsive. And we realized something was wrong, or I realized something was wrong when, as he was starting to inject, she said, it's burning, it's burning. It never burned before, so we stopped it. And we rechecked it and found that it wasn't in good position. So these are high concentration. So the patient only got like a half cc to 1 cc of the refill drug. But these refills have such high concentration of opiate that when you give just a small amount subcutaneously, you can have these systemic effects. So we stopped it, and it was like a sub-Q injection, and within about 5 minutes she started manifesting altered mental status, respiratory depression. She was treated with oxygen and stimulated, and within about 15-20 minutes it started to resolve, and she was okay within about a half an hour. But pump refills, common, still occur. Overpressure doesn't occur that much because of the valves, the check valves that are in place, but you can still overpressure a system if you give the drug, if you refill the reservoir too quickly, and the pressure is transmitted to the tubing, and it can be forced around the rotor and be injected into the neuraxis. The reservoir valves can stick, although they're pretty good now. With the new pumps, I haven't heard of much in the way of problems with that. Okay, overpressure, again, if you have your reservoir here and you fill it and you put in the stuff very rapidly and you cause a lot of pressure within the reservoir chamber, then you put pressure into your system here, and they can bypass the rotor because of this pressure and force itself out into the neuraxis. The reservoir valve this is the valve, check valve, and this is the open position. This is a collapse. Here's the bellows where the where the solution sits. This is collapsed. This is open. So you put your needle in here, and then you give your drug, and it flows in to your bellows and fills up. So here it is closed. So now here's a stop. So now you put your medication, your needle in, and you put your medication in. It can't go in because this stops it from filling, so you can't overpressure that way. But this had, in the old pumps, this could get stuck, and they had protocols for unsticking it. But in the newer pumps, I haven't heard of it being a problem. Again, this just shows you the reservoir being filled. I won't spend a lot of time on that. Overpressure can occur also by heating. Remember, you have the bellows. It's surrounded by a gas, a halogenated gas that puts pressure on the bellows to push the bellows closed, to push the drug to the rotor so that drug gets delivered to the rotor tubing, so then the rotor can push it out. So if patients go into a hot bath, the pressure in the system can increase, and you can get increased pressure going to the tubing to the rotor. That's about it. Okay, so procedural complications. So drug extruding into the subcutaneous tissue, more likely if it's an obese patient or deeply implanted pump and you can't feel the pump all that well. If it's a relatively new implant with serous collection, so you think you're in and you get fluid back, oh, I'm in, I'm getting fluid back, but it just might be serous fluid. If your refill is too early post-op, reservoir valve activation, and the maximum reservoir volume being reached. You may have reservoir valve activation with low temperatures, and also the maximum reservoir volume being reached. And so if you don't remove all of the residual volume in the chamber for the refill, and then you go to put in your solution, you may find a lot of pressure and resistance if you haven't taken all of the residual solution out. If you have a lot of air or air entry prior to your refill, air takes up space, so that's going to close the stem, the valve, and put pressure when you try to inject. So these are just some things that need to be aware of. So how do you minimize refill complications? You know, when you aspirate, you see air coming back in the tubing. So you have the needle in the reservoir and you pull back until you see air bubbles mixed with your solution coming back. When you go to fill, there's supposed to be a negative pressure in the reservoir. With the new pumps, I don't see it so much. I mean, used to see it with the old pumps where you'd put in your needle, you put your syringe on, unclamp it, and the syringe would actually suck the fluid in. But I don't see that happening so much with the new ones. What you can do, let me go back. What you can do is, if you're not sure you're into the reservoir, you can inject saline and aspirate and see if you get what you put in back. You can, if you think if there's a concern, you might be in a side port, or if you're in body fluid, like you have a serous collection, you can test for glucose. There shouldn't be any glucose in the contents of your pump reservoir, but you would find glucose in body fluids. And don't force the refill of the pump, the volume of the solution into the pump. Once you meet resistance, then stop. So that'll help prevent the valve from sticking. Okay. So what happens if you get discrepancies? Let's say you have a volume that you withdraw from your reservoir that exceeds the expected amount, and the expected amount is greater than or less than 25% of the predicted. So what you read from the pump is a calculated volume. It calculates it based on the rotation of the rotor, how much fluid it is calculated to be pushed by the rotor with each rotation, and so you set it at a certain amount to be delivered. That gets internally interpreted into how many rotations of the rotor, and then based on the rotations, how much fluid is pumped by the rotor, and then that's how you get the value of the residual solution that's remaining. It's not a measured volume, it's a calculated volume. So if you have a discrepancy that exceeds the expected amount, so you may have catheter obstruction or a granuloma or scarring at the tip where it doesn't allow it to empty out. You may have pump motor failure, and you might have patients who use the pump illicitly, thinking that they can inject illicit drugs into the system to get an effect. This has been reported. People taking drug out and injecting it systemically, people putting drug in thinking it's going into their systemic circulation. So these are some of the possibilities for volume exceeding the expected or reported amount. If it's below the expected amount, there may be overinfusion. Like some pumps, there's some patients where the volume is always lower in the reservoir than what is predicted. So I document what it is and I watch it over time, and it's always lower than what the pump says it should be. And again, if it's lower than what expected, there are patients who have accessed the reservoir illicitly to use the contents of the pump illicitly. These have been reported. Okay. Programming errors. This is another complication of intrathecal delivery systems. If you change your drug concentration, or doing bridge boluses, or you do complex or continuous reflex dosing, these can lead to programming errors that can lead to unwanted amounts of drug delivery, either more or less than what you would like the patient to get. Now, psychological images. One of the reasons we get a psychological evaluation, well, there are several reasons. One is to make sure that there's realistic expectations for the pump. I've had patients say, I want to get back to what I was 15 years ago when this happened. Well, there's no way I'm going to make somebody go back 15 years by putting a pump into them. There's just no way. So that's an unrealistic expectation. And until that patient gets some realistic expectations, you shouldn't implant. But another another reason for psychological evaluation is that there's some patients who have body image problems. That if their body is distorted, they are very disturbed and troubled by it. And so one of the things a psychologist should do is explore how the patient might respond to having a pump that protrudes under the skin, and how that might affect them emotionally, psychologically. So there have been pumps that have been placed and then a few months later removed because the patient says, I don't like it, I don't like the way it looks, it makes me look terrible, or I don't like the way it makes me feel, I don't feel right with it, get it out of me. And so these are some of the reasons for psychological evaluations, and if these aren't checked for ahead of time, then they would be psychological complications. Issues, MRI. So we get called about MRI. Well, patients with pumps, they can have an MRI. The only thing is the pump needs to be checked after the MRI to make sure the motor is installed or the rotor is installed, and that there hasn't been any changes in the programming. So in the MRI, the rotor is ferrous material, so it aligns in the electromagnetic field. So as the motor in the pump tries to turn, if the magnetic field is held in one position, the rotor could be stuck, if you will, or stalled. And there is part of the programming in the pump allows for detection of a stalled rotor. And it will come up that the rotor is stalled. And sometimes just reprogramming the pump can get it going again. Okay. Also, there have been reports, and it's been documented, that the pump heats up a couple of degrees by MRI studies. So it's not a big deal. You just have to alert the patient so they don't get concerned if they say, it feels hot over at my pump site. Well, for whatever reason, it can heat up, and some people are bothered by a couple of degrees. change in temperature. So if you just alert the patient to it and tell them it's not a big deal, it really doesn't do anything to alter the function of the pump. Electroconvulsive therapy. There's been concern about electroconvulsive therapy, whether the electrical signals that are generated might change the settings of the pump. It's a concern. It hasn't been studied, but it's easy enough to, if someone has a pump and undergoing ECT, you just check the pump afterwards. Okay, so here's a complication, surgical complication. Patient had interstitial cystitis, had a pump implanted. Here's the pump. There's the catheter. You can see the catheter, and you can follow the catheter all the way through, intrathecal. Now, about a month or so after the pump implant, patient started to get a swelling in her back. And so here, if you follow from here to here to here, and notice here it gets even more prominent, and here is a collection above the spinous process and below the skin. And here is a catheter going in. Here's a catheter here, here's a catheter, here's a catheter. So the catheter is going in here. You can see the catheter going in, and here's the catheter here. Okay, and now it's starting to get less as you go down towards the sacrum. So what is this? What do you do? I can tell you, looking at her skin, it was swollen, it looked purple, she was afebrile, had no elevated white count, she was otherwise asymptomatic, except she said, it's swelling in my back. So what is it? What do you do? We got this CT scan. Leaking. What do you mean leaking? Leaking what? No, not drug. How much drug is delivered a day? A half a milliliter? A half a milliliter a day, it will be absorbed. It's like a sub-Q injection. So it's CSF leak. So what happened was the CSF was tracking back along the catheter, following back where it went into the spine under the skin and collecting under there. So she, even though she had redness of her skin, when it was opened up, well, fluid was aspirated and sent for culture. It was clear. It was sent for CSF analysis. Everything was fine. And what she needed was to have figure-of-8 sutures put in to stop the CSF from backing up under the skin. So it's CSF tracking back along the catheter, causing a pseudoseal, basically. It's, what it was a pseudoseal, collection of CSF fluid outside this central nervous system, but it wasn't in direct connection with the neuraxis, so it was considered a pseudoseal.
So it was tracking back around the catheter?
Yeah, and leaking back. It happens. Okay, so the old system is pretty much gone. There may be some patients who still have it. New system. The new system was redesigned with simplified access. This had a screen here to minimize entry of anything but a 25 gauge needle. This allows for a 24 gauge needle. The access port is larger than in the old system. So it's easier to get into the side port because it's more funnel shape. It doesn't have a screen, and easier to get into the reservoir access because it's a little bit wider. And in the old system, you had a large amount of internal tubing. There's lesser internal tubing with the newer model. And the pump tubing to check valve. Again, it's just lesser tubing, so the amount of tubing from the reservoir into the side port is much less. I don't know what else I was trying to think about there. Oh, let me go back. Yeah, this is a side port, but I don't remember what the point of this was, so sorry. So the new pump is smaller in size, smaller in weight, but it is larger in reservoir volume, and it has two sizes, 20 and 40 mLs. And it has a flex dose option, and it also has a patient-activated bolus that, like a PCA type device that can be programmed for the patient to use. So those are the advantages. And now, so there are a lot of agents that you can use for neuraxial analgesia. How do you choose them? What do you use? Well, there was a polyanalalgesic consensus conference. There's actually been 3 of them. There was one in 2000, one in 2003 or 2004, and the last one I know about was 2007. And this was a conference that got together those individuals who are viewed as experts in the field of neuraxial analgesia and implantation. And they reviewed the literature, and I think this neuraxial consensus conference statement is in your folder on the hard drive, so you can take a look at it. But they came up with these recommendations. Now, these are their recommendations. They're not obligatory, they're not mandatory. This is a consensus paper. But the first line recommendations that they gave was to try morphine or hydromorphone, and they put in ziconotide as a first line treatment. Not everyone agrees with ziconotide as a first line treatment. The reason they put ziconotide as a first line treatment was because the amount of literature and evidence-based medicine that there was on the efficacy of ziconotide, that they felt they should put it as first line. Second line drugs to consider: fentanyl, morphine or dilaudid with ziconotide mixture, and morphine dilaudid with bupivacaine or clonidine as a mixture. So this is their recommendation. You try the opiates and ziconotide first. If that doesn't work, you try fentanyl and or one of these other mixtures. And if that doesn't work, then your third line of approach would be clonidine as a trial. And then you can use morphine dilaudid or fentanyl with bupivacaine, clonidine, and or ziconotide. So fentanyl is in there as a line 4 approach, and then you can combine that with one or more of the other agents as well. And then as a line 5 approach, ropivacaine, buprenorphine, midazolam, meperidine, and ketorolac. Then they list experimental drugs. These are drugs at the time in 2007 that were being looked at experimentally that could be considered for the future, but they didn't have very strong evidence for human use. Now, if you notice in here, ketamine is not listed. You may read and you may hear about ketamine being used in neuraxial infusions. It is not recommended, and it wasn't recommended by this consensus statement, because in animal experiments, ketamine intrathecally produced neurolysis, apoptosis of neurons and cell death. So that is why ketamine is not recommended. Now, the reason for showing you this consensus statement is that if you do pumps and you trial drugs, you do what you think is best, but you need to know what is out there in terms of recommendations. So if you veer from what is viewed as recommended by this group, you need to be able to justify and explain yourself should a problem develop. All right? So I don't use this consensus statement myself, this approach. I have my own approach, but I'm aware of it, and I can justify what I do in terms of the trials that I do.
Did they comment on baclofen?
Oh, baclofen. Yes. Thank you. I forgot about that. Baclofen was not included because, thank you very much, very important. Baclofen was not included because in the review of the literature at the time, it was only felt to be evidence-based for muscle spasm, not for pain. So because it wasn't efficacious for pain, there were no studies for it, they did not include it. Nevertheless, I can tell you that for some neuropathic pain patients who have muscle spasm or may not have muscle spasm, adding baclofen could be beneficial, and I would try it based on case reports and experience. But thank you for reminding me about that. Okay, so baclofen's not listed either, and neither is ketamine. Okay, so how do you do your trials? Who here has done trials with, say, Dr. Okay, how does she do her trials? She do single dose injection, continuous infusion? I don't even know what she, you know.
Just stepwise continuous.
Stepwise continuous. All right. The other question is, so the question is, do you, some places you go to will have the patient come in early and give a single injection, say, of intrathecal morphine and see how the patient responds, and send them home late in the day into the evening and get the response that way. Baclofen is tested also by bolus injection if you're going to use that for spasticity and you observe the response. But there's something to be said for continuous infusion. We'll go into that in a minute. Also, do you do epidural or intrathecal injections or infusions? Which is the better approach, epidural or intrathecal? Also, does the catheter location matter? If you have your catheter in the intrathecal fluid, does it matter where the tip is? So let's just look at a couple of these things. So if you have, here's drug level in CSF or tissue, whatever you're measuring over time. If you give bolus injections, the white lines, you give a bolus, so now you have a period of time for that bolus to get into what's called the therapeutic window. And once the drug gets into the therapeutic window, it can have its analgesic effect. But if you give too much drug and it goes out of the therapeutic window, you get into levels of toxicity. And so the patient may be have sedation or respiratory depression until the level starts to fall, and then they get back into the therapeutic window for a while. And then there's a time period when they have no effect because the drug, they have some drug level, but it's not enough to have an analgesic effect. Now, that's one scenario with a bolus. Another scenario with a bolus is you give a bolus and nothing happens. The patient doesn't respond. It could be you just didn't give enough drug for that patient, so it didn't reach the therapeutic window. Another response is that they get some relief, but for a very brief period of time. So the drug rises, gets into the therapeutic window, but it's not enough to be sustained, and then starts to fall. So they say, well, it helped me for maybe 20 minutes or something like that. And you expect morphine to last for several hours. So this might be an explanation because they had minimal amounts of drug in the levels that would be therapeutic for that individual. Now, looking at continuous infusion, if you start out and you run it at a certain level and then you start to plateau, then if the patient's not responding, then you can increase the infusion and allow it to get into the therapeutic window by increasing the infusion. Then you can push the drug if the patient says, I'm doing pretty good, I'm feeling better, I wish it could be more. So now you push the infusion rate up, but now you get into toxic levels as you push the infusion up. So now you turn the infusion down and you let it come back, and the patient gets back into a therapeutic window. And so you know this is what the drug can do. If I go higher, I get into toxicity. They get some benefit. The patient's going to have to decide, is this amount of benefit enough for them to undergo an implantation and to have the device? So I prefer continuous infusions myself. You can titrate it every few hours, and you can finally titrate and mimic more of what it would be like with a pump than having single bolus injections. Now, does it matter where you put the catheter? It does matter depending on the drug. So where do local anesthetics act? Let's say you're using a local anesthetic, bupivacaine. Where does local anesthetic act? Anybody? Anesthesiologist. Where does it act? On what? Speak up. Speak. Yeah, okay, but yeah, let's be more, forest rather than the trees. So it acts on the nerve fibers, right? It affects the nerve fibers, right? It blocks nerve conduction in the nerve fibers. Where do the opiates and clonidine and baclofen act? In the dorsal horn of the spinal cord. So now, let's say you have your catheter in your CSF in the lumbar region, and let's say we're dealing with pelvic or lower extremity pain, let's say. So now your local anesthetic would be working on your fibers here, but they would be getting all the fibers that go to the lower extremity. If you give opiates, clonidine, baclofen, they have to diffuse up to wherever the spinal cord segment is for the area of nociception that you're dealing with. So let's say you're dealing with, to make it specific, an L5 radiculopathy. So if you follow the L5 nerve root up, you can see that the segment for the L5 nerve root is somewhere, around T11, T12 vertebral body. That's where the spinal segment is for that nerve root. The nerve root comes down in the caudate equine and then goes out to the periphery. So if you have a L5 radiculopathy that you want to do a neuraxial infusion, it would be best to have your catheter tip as much as possible, as close as possible, to the L5 cord segment of involvement, because your local will get the nerve roots and your other drugs you would need less concentration of the other drugs to go into the spinal cord segment, into the dorsal horn of that segment to have its effect. If you were to give the drugs here, there's a concentration gradient. So now you have to give enough drug to diffuse up, and you're going to get all these other neurons involved more so than if you have the catheter tip close to where the segment is. So it's my opinion, it's an opinion that it does matter where the tip is. And in terms of epidural versus what do you call it, intrathecal, it would be better to have intrathecal administration to mimic what you would be doing ultimately. But if you have somebody with upper extremity pain, with arm pain and neck pain, well, it's going to be hard to get a catheter going up to the cervical region. So I would, if possible, put a cervical epidural catheter and run epidural drugs, and then convert them, if they worked, and the patient went for a pump, convert that from an epidural to an intrathecal mode of delivery. So I've done that a couple of times. All right. So just a couple issues. All right, so that's it.